Good morning, ladies and gentlemen. At the onset, I like to thank all my friends from Rajput Endocrine Society for inviting me to discuss on this topic, which is now a hot burning topic virtually discussed in every physician forum and now even discussed beyond physician forum. Now we know type 2 diabetes never comes alone. All of us as a physician who are seeing diabetes from years, majority, more than 3/4 of the people who are suffering from diabetes are obese. Most of them are having hypertension. Most of them are having dyslipidemia. And this is because the mother of all these metabolic problems is insulin resistance and excess of visceral adipose tissues. And when not tackled in time, we have complications related to these problems. Unfortunately, because of lack of drugs to address this excess adiposity, we are not dealing it an upstream approach. In fact, we are treating diabetes separately, we are treating cardiovascular disease separately, we are treating kidney disease separately. But now, with the advent of drugs which provide organ protection, now we have started talking about different types of drug. And the two drugs which have actually changed the entire scenario of type 2 diabetes management are SGLT2 inhibitors and GLP-1 receptor agonist. And now the latest one is combined GLP and GIP receptor agonist. And obesity is one field where treatment is actually very frustrating, both for the treating physician as well as for the patient, because the amount of weight loss which is happening with the currently available oral drugs is so minimalistic that patient often throw away those tablets, and as a physician we also know what is going to happen. Lifestyle intervention has limitation. Beyond certain point, weight is not lost. So therefore, we are now in an era, exciting era, where newer and newer molecules to tackle obesity. And then when you are tackling obesity, there are more than 100 diseases which are linked to obesity. Actually, you are addressing all those diseases simultaneously. And that is why newer and newer indications of these drugs are coming. They come as an anti-obesity measure. Then after 6 months, a new approval will come that they will reduce cardiovascular disease, they will reduce your renal disease, they are beneficial in PCOD, they are beneficial in obstructive sleep apnea, they are beneficial in MASH. So that's how any disease which is linked to obesity is actually going to be benefited by use of these drugs. As I have told you, diabetes and obesity are linked with each other. All of us are born with our genetic capacity to store fat inside our adipose tissue. Now, whenever this genetic capacity is exceeded, the excess fat spills over and comes into blood and get deposited into visceral organs. Normally, visceral organs are free of adipose tissue or they are having minimal fat. Now, this excess fat in visceral organs is responsible for various problems, including MASH. When it gets deposited in pancreas, you have defective first phase secretion and second phase secretion of insulin, and patient develop diabetes. If it goes into the muscle, you have defective utilization of glucose, so you have postprandial hyperglycemia and marbleization of muscles. So excess adipose tissue and diabetes are closely linked, and it has been shown that if you reduce your beta cell, if you reduce your body weight, it will improve your insulin sensitivity, your beta cell function, and now in endocrinology field, adipose tissue is recognized as the biggest endocrine organ. And when there is an excess fat deposition inside it, its blood vessels get inflamed, there is release of inflammatory cytokines, and that is why you have seen CRP levels are high in patients who are obese otherwise. Those hospitals where health checkups are done, now CRP is included as a routine marker, which is coming at as high. So we have to reduce adiposity irrespective of presence or absence of metabolic diseases. There was an era, I still remember 20 years back in RSSDI, I have given a lecture on metabolically healthy obesity. What is metabolically healthy obesity? That you are obese, but you does not have any metabolic disease. So we used to call it metabolically healthy obesity. But now we have data that this is a misnomer. This term is now thrown to dustbins. Even metabolically healthy obese have increased long-term morbidity and mortality at least 2 to 3 times higher as compared to those who does not have obesity. So first, as a physician and then to the population and social system, we have to accept obesity is a disease. Even if you does not have any other problems like hypertension, dyslipidemia, diabetes, or so on. Obesity is a disease. So first we have to recognize it, which we does not recognize, which we does not accept. And why I am saying so, if in an audience of 100 people sitting here, if we will do a body composition analysis and do BMI and waist circumference and to find out how many of us who are sitting here as per Asian Indian cutoffs are obese, we will be surprised that at least more than 70% of the people who are sitting here are obese. But we does not recognize it. So what to talk about our patients, why they will understand it. So as a physician, when we have to first understand it, then this education will be imparted to our patients. And there are very strong clinical evidences which support that if you reduce your body weight, you will do management of diabetes more effectively as compared to where we will not address obesity. If we see the evidences, this is systemic literature review, where each 1 kg reduction in body weight will result in reduction in HbA1c by 0.1%. And you know, if you are treating a patient of diabetes and patient gained 3 kgs of body weight on your therapy, you will not get the benefit of reduction of HbA1c by 1%. So it will negate the benefit of 1% reduction in HbA1c. And 3 kgs gain in body weight is quite common with type of therapies which we are using necessarily or unnecessarily. I will give you an example. If you screen the prescriptions, pregabalin is one drug which has been written, I do not know, for so many reasons, God knows or doctor knows. With pregabalin, if you search the literature, 6 to 12 kgs of weight gain happens. And then we ask our patient to lose body weight. भाई उसको बार बार बोलते हैं भाई वजन कम कर ले, वजन कम कर ले. And out of frustration, patient आपको छोड़ देता है या दवाई खाना छोड़ देता है. So basically we have to choose our therapies judiciously. Therapy should not promote weight loss. Then open label randomized controlled trial at 12 months. If somebody is losing body weight, even diabetes remission is possible. Nowadays patient comes because on social media and net, concept of diabetes remission is very popular. There are many famous studies also. And in this randomized controlled trial, for every kg weight loss, there is 18% reduction in risk of diabetes. So there are evidences, and based on that, worldwide, all big societies have given recommendation. ADA and EASD, they have given recommendation that 5 to 10% weight loss, you have metabolic improvement. If you have more than 10% weight loss, there will be remission or reversal of diabetes. There is a big lecture and debate, the difference between remission and reversal. Two are different terminologies, although they are used interchangeably. So there is remission or reversal of diabetes, and it depends on the magnitude of weight loss, which decides improvement in various comorbidities which are associated with obesity. Therefore, if somebody is losing 10 to 15% of the body weight, your MASH resolution, your diabetes remission, your improvement in OSA, अपने पार्टनर से पूछिए, obese आदमी से पूछते हैं कि आप रात को खर्राटे मारते हो नहीं मारते, उसको कभी नहीं पता होता. Everything will improve actually. So weight loss is of paramount importance. When it comes to HbA1c, this is a study from US, real world study. Patients were followed. Unfortunately, in our India, follow-up of the patients is actually very poor. and we do not have data how many of our patients are actually at 1 year, 5 year, 10 year, how they are doing. In this study at 1 year and even at 5 year, they have a data which have shown that simply with reduction in body weight, large number of type 2 diabetic individuals are able to maintain their HbA1c less than 7%. So therefore, weight loss is like a therapy. It is like a drug. And when you see the effectiveness of weight loss therapy, virtually the amount of HbA1c reduction which is happening is as good as we see with some of the drugs. The only limitation is absence of therapies. Now we have different types of therapies available to us. One is GLP-1 therapy, which you will listen in next lecture. Another is combined GLP and GIP therapy, which I am going to discuss. I am not going to discuss anything about the drug. You can ask from me in question and answers. I am not going to discuss anything about the drug. There must be thousands of lecture already happened in Rajput. So there is no point in repeating those surpass trial, surmount trial. आप सबने वो सुन रखे ही होंगे. So you can have just question and answer session, your confusions, which we can discuss. So this is a very simple small case study. A 55-year-old female with type 2 diabetes and obesity. If you see BMI 35, which means patient is obese, blood pressure 140/90, so patient has type 2 diabetes, hypertension. What is missing here is in the diagnosis obesity. Still in our prescriptions on papers, obesity is not written even as a diagnosis. So if we are not writing it as a diagnosis, it means we are not identifying it. So it is not written here. So obesity is missing. So it has to be BMI is 35. And then if we see the investigation, HbA1c is 7.6, EGFR 98, there is mild elevation of SGOT-PT, which is quite common because MASH is very common. Patient ultrasound करा के लेके आता है, मेरे को fatty liver हो गया, उसको बोला तेरा BMI 35 है, fatty liver नहीं होगा तो क्या होगा भाई? So they does not want to understand it. Total cholesterol, LDL, everything has been mentioned, and he is on these drugs. Oral semaglutide, because this is a Lilly lecture, so here semaglutide oral is mentioned. Patient is on oral semaglutide, and the dose is 3, 7, 14, whatever you wanted to think, it is totally up to you. Aspirin, rosuvastatin, and olmesartan. And with these therapies, patient HbA1c is still high, patient is obese, BMI is still very high. And what are the therapeutic targets? Considering the age of the patient. Now we know there is no single HbA1c for each individual of type 2 diabetes. So here the HbA1c target, considering her age, is low. If it is possible, we can reach to less than 6.5%, which is now possible with the type of therapies which are available to us. We have a weight loss target, patient is obese, as I have told you, 10 to 15% of loss of body weight. It is now possible that remission of diabetes is possible. Then blood pressure target, LDL target. And what are the options? You can discuss with such type of patients. Now the availability of drugs, combined GLP-1, GIP-RA, tirzepatide. Now whenever we are initiating these drugs, first visit we have to pay some times because these molecules are not as innocuous as our DPP-4 inhibitors, which we are writing left and right without discussing anything to the patients. There are some initial side effects which are GIT related. There is some degree of muscle loss which is going to happen, which is quite fashionable in our physicians forum to discuss. Muscle loss का क्या करेंगे? और मैं हमेशा यही पूछता हूँ, बैरियाट्रिक सर्जरी जब हो रही थी तब हम में से किसी ने मसल लॉस के बारे में नहीं पूछा. एनी टाइप ऑफ वेट लॉस, इवन लाइफस्टाइल इंटरवेंशन, ड्रग्स, बैरियाट्रिक सर्जरी, जिस भी तरीके से वेट लॉस करोगे थोड़ा मसल लॉस भी होगा ही होगा. It is not possible that you will only have fat loss and you become Herculean next day. It is not going to happen. So with whatever form of weight loss therapies you are using, you have to change diet. You have to improve your protein intake, which is drastically low in our diet, and you have to begin some resistance exercises at least twice or thrice in a week, if not daily. All these things needs to be told to the patient at initiation, and then regarding GI tolerance and how the dosage needs to be escalated, that should also be told to the patient. The next important point which needs to be told is realistic expectations, because patient often read only internets or only read positive reviews that somebody has lost 25 kgs of body weight. Now they does not know, we does not know, nobody knows on this earth which patient is going to lose how many kgs of body weight. So a realistic expectation, how soon weight loss is to be expected, that has also to be told. Otherwise patient सोचता है इतनी महंगी दवाई है, एक इंजेक्शन लगाया, अगले हफ्ते उठूंगा तो पतला होकर मिलूंगा. तो ये सब चीजें हमें on ground first prescription पे करनी पड़ेंगी. Why it is important? If you see the discontinuation rate of these drugs, it is very high. Within first 3 months after starting the therapy, more than 50% of the patients stop taking them. At 1 year, more than 70% of the patients stop taking them. So there are some realistic things of our society which we have to understand. So we have to pay some time. Education is very important so that acceptance and long-term continuation of these drugs will take place only then, and only then it is possible to achieve the desirable goal. Whatever science we have discussed, for that science to come into practice, we have to pay some time. Now this is tirzepatide, which is combined GLP, GIP receptor agonist. All of you must be using with the name of Mounjaro. Very popular. Even those who are not doctors, they are writing it, they are prescribing it, and people are using it. So हम तो ऐसे ही खाम का discuss कर रहे हैं, सब कुछ social media पे available है. And it is available with the name of 2.5 milligram. The dose has to be escalated every month. The maximum dose is 15 milligram. It is not 10 milligram. But the difference between 10 and 15 milligram in terms of weight loss is very small. So therefore, we can use 10 milligram. If needed, patient can go up to 15 milligram dose. So this is, as of now, the maximum permissible dosage of tirzepatide available to us. So this patient was initiated on tirzepatide. Dosage was gradually escalated. Again, since this is a standard recommendation, but in real world, sometimes we do not go that slow. We can increase even faster, or you can go even slower. If somebody is developing side effects even on 2.5 milligram, which is GI, there is no need that compulsorily we are going to increase next month. We can continue same dose for 2 months or 3 months also. So those things we have to individualize depending from patient to patient. And on follow-up, as I have told the concept of diabetes remission, the HbA1c is reduced from 7.6 to 5.8%, which so many senior to me are sitting here, or even my colleagues are sitting here. We hardly have seen our people of type 2 diabetes reaching HbA1c of less than 6%. So it is now possible. Weight has been reduced drastically from 84 kgs to 74 kg. But remember another realistic thing. Whenever you are treating obesity in type 2 diabetes, the degree of weight loss is almost 50% as compared to patients of obesity without diabetes. Now this is true for both the molecules. It has been shown in the trials. There are 2 trials, SURPASS trial and SURMOUNT trial for tirzepatide. One done in type 2 diabetic patients, SURMOUNT done in obesity patients. Now often pharmaceutical companies will only show you the maximum data. In SURMOUNT, it has been shown up to 22% loss in body weight. But that has been achieved only in obese individual without diabetes. Those who are having diabetes, there the weight loss happened to the tune of 12 to 13%. Same is true for GLP-1RA semaglutide. Maximum weight loss is 15 to 16%, but in diabetic population, 7 to 8% weight loss. So diabetic population, for so many reasons, which we can discuss later on, loses body weight, which is reduced as compared to non-diabetic population. So therefore, again, a realistic expectation, a realistic goal needs to be set up whenever we are treating our patient. For plain obese, it is different. For diabetes and obesity, it is different. So to summarize this case, at 6 months, weight is reduced, BMI improved, HbA1c has gone to a non-diabetic range, BP improved, and initially, as I have told you, there is loss of appetite, early fullness, mild nausea. Some patients even may develop diarrhea or may develop constipation. That is why you have to improve the bulk and hydration. And after 6 months, patient started tolerating them, and patient continues to take and enjoy their life. So key takeaways: obesity, first of all, specifically abdominal and visceral adiposity, needs to be identified as a disease. Whether patient is having diabetes or not, that's another issue. When it is there, they become 1:111. Targeting obesity along with glucose control is very important. Now we have evidence that in real world, using GLP, GIP receptor agonist, tirzepatide deliver meaningful reduction of body weight. HbA1c provide good metabolic control. There is reduction in blood pressure. There is improvement in lipid profile, improvement in CRP and other markers of inflammation. And in such patients, until and unless cost is a barrier where sometimes we cannot use despite knowing all the science. This is also a hard reality. Despite not knowing all the science, if our patient cannot afford a drug, then we should not prescribe to him or her that drug and make him feel that he is missing something. Thank you very much.